All right. Hi, everyone. Thanks for coming back from lunch. I am Melissa Tsuboyama. I'm a pediatric neurologist, epileptologist at Boston Children's Hospital. I did do a year, bless you, at Nicklaus Children's Hospital for one of my surgical training years. As Tracy mentioned, we'll be talking about SUDEP and mortality in LGS. I don't have any relevant disclosures or conflicts of interest. Just to give you a sense of what we're going to talk about here, I find it's always nice, whether it's in the clinic or giving a talk, to give you a sense of where we're going, like a roadmap. So we'll talk about the problem, the ugly truth of this problem of mortality in SUDEP, and then identify risk factors, talk about some new data and discoveries that have come out in the last few years, and then finally, what do we do with this information? What are the challenges in front of us? And then where do we go from here? So unfortunately, mortality in LGS is very high, and it is much higher, up to 14 times greater in children with LGS than in children in the general population, including in other children who have epilepsy but not LGS. Neurological causes are the most common when you look back at the antecedent leading up to the death. So Tracy had talked about, oftentimes aspiration events result in it, but oftentimes there'll be like a long seizure leading up to the aspiration event, perhaps. External causes of death, like motor vehicle accidents or injuries, overdoses of getting into something in the cabinet, are less common in people with LGS compared to the general population. And there's lots of different numbers about when mortality is. There's varying studies, but it seems to be in the late teen to early 20 kind of time period. Obviously, everybody is different. This is not to say that that is specific to your situation either. The mortality rate is also hard to define because, as we have seen over time, that we've been able to understand, or we are emphasizing rightly so, that LGS is an umbrella diagnosis that is a syndrome caused by a lot of different things. It can be difficult to pinpoint exact differences from patient to patient or child to child, person to person, as to what the mortality would be. But in some studies that have looked at this, they looked at people who had epilepsy or status epilepticus and used a certain number or kinds of medications and then had developmental delay, and then excluded the people who had Dravet syndrome specifically with all of these, and kind of had included them in a group that they would call probably having LGS, and then narrowed it down to people who had all these symptoms, but that everything started before they were 6 years of age, to have like a narrower definition. And that was kind of the best they could do with some of the data available to isolate people who have LGS, and found that over a 10-year period, there was a 10% rate of death in people with probable LGS compared to people without LGS. And then with a more narrower definition, it was 3%. And honestly, I think at the end of the day, what this tells us, there's no number that's a good number, right? This is death that we're talking about. But I think this helps us put it into perspective from a large group analysis over a long period of time. We need to know kind of the demons that we're up against. And then more specifically, sudden unexplained death in epilepsy, or SUDEP. I wanted to lay out some of the definitions here. Some of them will be relevant to what I talk about. But it is sudden, unexpected, non-traumatic, non-drowning related death in a person with epilepsy that may or may not have had evidence of a seizure leading up to death, excluding status epilepticus, and also involves an autopsy that does not show another cause for their death either. So that is how you actually diagnose somebody with SUDEP, and there's actually been a lot of work looking into the fact that sometimes when an autopsy is being done, people will put it was cardiorespiratory arrest because what happened right before is that your heart and lungs stopped, but what caused that is what's a little bit unclear. And so that has also been something that has made studying SUDEP a little bit more challenging. Then they have broken down other categories here. So there's definite plus, where you have the definition of SUDEP, but then there's also probably something else that also contributed to death. Oftentimes this is used in the adult epilepsy world, where maybe you also have coronary disease or something like that. Probable SUDEP is when you have all of the same criteria except there isn't an autopsy that's done. And then possible SUDEP is, as you might imagine, where it might have been SUDEP, but they can't exclude, the other causes can't be excluded. And why is SUDEP awareness so important? Basically because, unfortunately, anybody can be at risk for it who has epilepsy. So it can occur in someone whether you have focal seizures and have had focal seizures all your life, or generalized seizures. It can even occur, although it's rarer, in people with epilepsy who have never had a generalized tonic-clonic seizure. It can occur in children who have what we used to call like the benign epilepsies. We have taken that word out because there's nothing benign about epilepsy. So we call it self-limited focal epilepsy of childhood. You might have heard that referenced as something like Rolandic epilepsy, for example. And so this is not meant necessarily to like scare anybody into a panic, but it's more about knowing that it is possible to have to be at risk of SUDEP when you have epilepsy of any type. We'll go into details in a few slides about what are the things that put someone at higher risk, but it is true that no one will ever be able to tell you, or they're lying if anyone ever tells you that your child's risk of SUDEP is 0 and they have epilepsy. There have been lots of studies that have confirmed that, unfortunately, SUDEP is not talked about enough. Obviously, nobody wants to, let alone come up on a podium and talk to everyone right after lunch about this kind of topic. But it is important because it can affect anybody. And in one study, there were 16% of next of kin who were interviewed after SUDEP of a loved one that were aware, meaning that there were, 84% or so that did not have it discussed. Or if they did discuss it, it certainly wasn't something that was honed in on in the discussion. Of those 16% who did have SUDEP discussed with them, 74% were glad it was discussed, meaning that it is possible that like 25% of you here are not a fan of this, of wanting to hear about it. But of the 84% of people who did not know about it, 78% wish that they really had known about it. And I think what's important about it is that it can help in two ways. Knowing about SUDEP and what are the risk factors help us know from the parent, family, care provider, caregiver, and medical team what the child's risk is of having SUDEP, and then what can we do to modify it, and what are those things that we can do. And in terms of how common SUDEP is, so it is very rare in people who have newly diagnosed epilepsy, presumably well-controlled epilepsy at that point. So it's 0.09 per 1,000 patient years. So if you were just to say in 1 year, that would be 0.09 people out of every 1,000 in 1 year will have SUDEP after being recently diagnosed with epilepsy. So it's incredibly rare. In people who have difficult to control seizures or medically refractory epilepsy, it's higher. It's up to, and I write up to because there's a lot of different numbers thrown out there, but up to 9 per 1,000 people with epilepsy in a given year. When we look at this across all age groups, it's anywhere from like 0.33 to 1.35 in one group, so there's a lot of the numbers are lower than that 9 per 1,000 I talked about. And then people have looked at, in children specifically, what the rates are, and it's up to 0.43 per 1,000 children. So usually people say like 1 in 4,500 children with epilepsy die of SUDEP. So what are the risk factors of SUDEP? Because we talked about it could happen to anybody, but there are certain things that really increase someone's risk. Having generalized tonic-clonic seizures, which unfortunately is common, as Tracy had shown before, in LGS, is a big risk factor, and it increases your risk. It makes you 10 times more likely to have it. If you have especially more than three or more in a year, it even more significantly elevates your risk of having SUDEP. Having seizures in the middle of the night is also a major risk factor. Not taking your medications if you're supposed to be taking anti-seizure medications also increases your risk. And poor seizure control, I don't have really good numbers for that, but essentially saying that if you need to be on multiple medications or not adding another medication when you should be, is a risk factor. And then not treating with anti-seizure drugs if it's not clinically indicated is a risk. It's also worth mentioning that this risk exists if you're ever in the process of tapering off of a medication. There are some people who, it is important to wean off, because I agree with what Dr. Knupp said before too about trying to minimize how many medications you're on, and if you're on like 4, 5, 6, 7, it can't be that all of them really are contributing that significantly, and so there's certainly a role. But also there is a risk with any anti-seizure medication reduction. And this also holds true, I think, in people who do not have LGS or actually are at a period where they're able to come off of medication because their seizures have been well controlled. We still have to think about this risk. There's a couple things that perhaps are protective factors. So I put an asterisk there. With someone sleeping in the same room or basically having supervised sleep has actually shown to be associated with a decreased incidence of SUDEP. And then listening devices in the room. So I think a lot of people these days use like a baby monitor, audio monitor, has also been shown to have or suggest an association between a lower risk of SUDEP and if you do one of these things. It still needs to be more highly looked at, but many different studies have found something relatively similar, which has led to some of the guidelines and recommendations that we'll go to at the end of this. In terms of SUDEP biomarkers, so I wanted to talk to you a little bit about the science of SUDEP because I think it's helpful for everyone to understand what we do know, what we don't know, and what we're maybe starting to understand here. And so Dr. Porter had talked about natural history studies and looking at biomarkers. So biomarkers, like this key term that everybody is using these days, about ways to figure out whether it's a diagnosis or the likelihood that something is going to happen without it happening. So are there signals that we can look at? Is there something in the history? Are there EKG changes, EEG changes, other data that we can collect that'll give us a better sense, in this case, of whether someone is more likely to have SUDEP or not? Because if you're at higher risk, maybe the next step would be, what can we do for those particular people with highest risk? Or certainly if you weren't using a baby monitor or having some sort of seizure detection device, you will definitely want to start using it now, and clinicians would be more likely to recommend one to you. So this is an EEG. The tail end of an EEG of somebody who had a secondarily generalized tonic-clonic seizure. So it started as a focal seizure and then became generalized, and then it stopped. So the first few seconds that you see on the slide there are the end of the clonic jerks here. And it's not super relevant, but like the top half are the left electrodes on the left side of the brain, the bottom half are the right electrodes, and the two middle lines are like kind of the midline. And the right side, you see a lot of movement there. That's just like people are turning him and moving this person over to the side. That's not brain activity. But what you can see, I think, is after the seizure stops, the lines pretty much go flat in the brain for a little while, and it stayed flat for a little longer, and then eventually things started coming back. That is what we call postictal generalized EEG suppression, or PGES. And initially there was thought that if you had this after a seizure, that you were at higher risk of SUDEP. Patients with this finding, or people with epilepsy who had this finding, were more likely to be motionless and unresponsive in that postictal state. And there was one study that showed maybe this was related. I bring it up more because this is a very common thought, but it was only found in this one study, but everyone has talked about this one study for a long time, and then actually there have been subsequent studies done that did not replicate this result. So whether there are biomarkers or any signs on the EEG that we can tell about someone being at high risk of SUDEP may be there, but this is not clearly one of those yet. Another one is electrodermal activity, or EDA, which is basically like the skin sweat type of reaction that your body has. More scientifically, I guess speaking, it's this balance between your sympathetic nervous system and your parasympathetic nervous system, with those being your autonomic nervous system, right? So your sympathetic nervous system is like your fight or flight, and parasympathetics kind of balance that out. So you have this balance, but when you have too much sympathetic activity, you get this increase in electrodermal activity. And there's actually been a lot of work showing that electrodermal activity does change in a seizure and following a seizure, even when you have seizures without like a shaking component. So it is a metric that is very closely being looked at for seizure detection devices, which is another interest of mine, but I'll let some of the other experts talk about that. There was actually one person who had SUDEP while wearing an Embrace watch, one of the seizure detection devices, the only FDA cleared one that's available right now. And it did in fact confirm in this person who had SUDEP that there was this huge surge in postictal EDA right after the seizure and before they ended up dying as well. So this is a heavily researched area. It's not something that you can just go to your doctor's visit and be like, so what's my child's like EDA like? But it is something that is being monitored in people at least, and what a lot of seizure detection work is looking at, because we're thinking that that might be a better way to detect seizures, not only tonic-clonic, generalized tonic-clonic seizures, but maybe some of these other seizures without that shaking component. And then there's EKG biomarkers. Now, I became a neurologist because I like the brain, not the heart, but it turns out that I'm gonna have to figure something out, because it turns out that they're kind of related. I think, in my biased opinion, because the brain, is kind of in charge of everything. It's super important. So, but as a tutorial for all of us, this is a part of an EKG, and I'm gonna be mentioning some letters, so I just wanna give you some orientation here, that when your child would get an EKG, that's when they put the stickers on the chest and measure the heart activity. You have a P wave, a QRS complex, that's the triangle part. There's the T wave, and then you go on to the next one, and that's a heartbeat. So when a heartbeat, it's all those things happening. And then you look at, so what cardiologists, I hear, do, is that they look at, like, what does the P wave, what does the QRS wave look like, what does the T wave look like, and also what is the time frame between the P to the R, from the Q to the T, and all of these things in between, and they measure them. And it turns out that all of these things are actually relevant for epilepsy and for SUDEP in particular, and mortality in general. So there is this concept now called the epileptic heart that has been coined, where they talk about the heart and coronary vasculature being damaged by chronic epilepsy as a result of, when you have epilepsy, when you have seizures, you're getting this surge of catecholamines and hypoxemia, decreased oxygen, that lead to electrical and mechanical dysfunction of the heart. So there is some relation, and there's actually been a few promising EKG biomarkers that are coming out. So one of them is this QT dispersion. So from measuring between the Q and the end of the T wave, you measure that, and there's supposed to be a certain duration, and you compare the duration from, like, in a person, because there's going to be some variability from heartbeat to heartbeat, and you compare how similar they are from heartbeat to heartbeat, that QT interval. This is a marker of how good the heart is at kind of rebounding after each heartbeat, like it's doing something with, pumping the heart and all of those things. And it's about how good the heart is at kind of resetting to get ready for the next one. Having increased QT dispersion, meaning that there's too much variability in that QT duration has been associated with sudden cardiac death. And it has been found in up to a third of people with epilepsy. So cardiology looks at this and is looking at, causes of sudden cardiac death in anybody, whether you have epilepsy or not. The neurology community, we're looking at it as, well, there are people who have epilepsy who die suddenly, and it could be cardiac death related, and so we're looking for a lot of the overlap there, and it does seem like there's going to be something in this realm. So QT dispersion is one. This other one is much more talked about. It's this T-wave alternans. So there's another segment, or the T-wave, we talked about the T-wave, and there's a little bit of variability in how tall it is and how the appearance of the wave and how much it goes like down before it goes up, or up and how far down it goes afterwards. And if you have too much of that, this T-wave alternans is not normal and is an indicator of cardiac electrical instability. Also associated with sudden death and cardiovascular mortality, and also found to be significantly increased after generalized tonic-clonic seizures, even when you compare it to non-generalized seizures. So this view on the left here is to just show you what they do, because as soon as I heard about this, I was like, okay, are we going to start looking in for this T-wave alternans in everybody? Like, do I have to start learning how to read EKGs better? But it turns out that there is a little bit more math or computer necessities that are needed. But basically, you look at each beat, each heartbeat, and you look specifically at the T waves, and you kind of like group them into two categories, and then figure out the average of those two categories. You look at the T wave, and then you basically put them on top of each other and see how similar or different they look. And if they look too different, then there is like an increase in this T wave alternans, and there's ways to make that into something more mathematical. And then the graph on the bottom shows us how prior to the seizure, the people who ended up having what they were terming here complex partial seizures or focal seizures with impaired awareness or generalized tonic-clonic seizures they didn't say exactly how long before the seizure, but at some point before, their T-wave alternan marker was about the same. So it's not something that necessarily is constantly present, but then the seizure happens, and then in the first up to like 7 minutes or so after the seizure, people with generalized tonic-clonic who just had a generalized tonic-clonic seizure have a much higher T-wave alternans, and then it slowly kind of trickles back to its baseline. This metric has also been compared in people who were just diagnosed with epilepsy and people who have long-standing and difficult to control epilepsy, and it's different. And if you recall, when I was talking about the rates of SUDEP, people with newly diagnosed epilepsy and potentially easier to control epilepsy had much lower rates of SUDEP. And this is supported, I think, or corroborated by this graph on the left that shows that, so at baseline, people with chronic epilepsy and newly diagnosed epilepsy, their T-wave alternans metric is kind of similar. But then at their maximum, because people will look at the extent of the variability and, you have a maximum TWA, even the people with the newly diagnosed epilepsy never reach above that 47 microvolt threshold that there is for that's what's abnormal. Whereas people with chronic epilepsy and who have an increased risk of SUDEP, everybody was above that threshold. So TWA is certainly something that is relevant in people with refractory epilepsy. And then this table or this graph on the right is just showing that all of the cardiac things that are related to TWA and how that compares to having drug-resistant epilepsy. So you can see in the blue, there's somebody who has stable coronary artery disease, and then you talk about people who have heart attacks and who have not heart attacks and cardiomyopathies and all these different heart conditions and where their TWA is. But people with drug-resistant epilepsy can have at their maximum degree of variability in this measurement is similar to that of somebody who had a heart attack. A STEMI is a ST elevation myocardial infarction. with with VTAC, ventricular tachycardia. So if you just think about that, I think sometimes for people, especially who don't understand epilepsy, obviously not in this room, but when you're talking to other people, it's like, this is what we're dealing with, which is a pretty important distinction, I think. And then one last EKG biomarker that is being looked at is heart rate variability. So there is a certain degree of change that you should have in your heart rate from beat to beat. And it is, again, another way to measure the difference between your sympathetic and parasympathetic inputs and how they're kind of balance each other. Having low heart rate variability means that you have decreased vagal tone or higher sympathetic tone, so there's too much of the sympathetic tone. And this is also linked to risk of sudden death in healthy people. It's also been shown to be reduced for several hours after someone has had a generalized tonic-clonic seizure. And it also seems to be related to T-wave alternans. So there are people who, when you have a high and abnormal T-wave alternans, you tend to have reduced heart rate variability. So what we want is that heart rate variability. We want your heart rate to be able to kind of make some changes over time. And you don't see that as much in people who are at risk of sudden death. There is one other marker, but it's like still very, very new, related to some other kind of cardiac heterogeneity. But I think the point of this being that it turns out that it might be some of the way forward from a SUDEP research and therefore intervention standpoint will be in the cardiac realm. So what do we do now? Well, we know then that sudden cardiac death is nearly threefold more frequent in people with epilepsy compared to people in the general population. And as I have just shown you, T-wave alternans and that heart rate variability seem to be pretty good predictors of cardiac mortality and even arrhythmias in the cardiac and general population world. And so it's time that we make that part of the normal conversation, I think, about SUDEP causes as well. And so what do we do with this? Well, there are ways to look at. One thing that has been good about a lot of the different wearables is that we're able to get EKG information. There's a lot of struggles that we have with wearables that are being worked on, but we usually are pretty good at being able to get some sort of EKG rhythm. And so from there, we may be able to begin extrapolating or getting information on heart rate variability and T-wave alternans. And what the next step would be is to involve these metrics in seizure detection. And there will be eventually, I think, some work in whether some of these things are changing, certain EKG metrics are changing leading up to a seizure, like up to 30 minutes before a seizure, in which case then we can start using these as part of the model for seizure prediction. And so all of these things are being looked at, but we should all be, I think, have that in our forefront so that you're also able to advocate for this. There has been so much work looking into SUDEP now, although we have a long way to go, but what we have found already so far has even led to recent meeting of the minds of the International League Against Epilepsy and the International Federation of Clinical Neurophysiology, that they even released practice guidelines recently, formally recommending clinically validated seizure detection devices, in particular for people who have generalized tonic-clonic seizures, so whether it starts focal and becomes generalized or it just is generalized from the beginning. Especially if there is somebody who would be able to intervene. So, you know, I see children with epilepsy, in particular people who might be surgical candidates, and then the other kind of clinic that I also have is in first like seizure detection monitoring. And unfortunately, as many of you may have experienced, a lot of insurance companies are not have not yet caught on, I think, to how important it is. So I was very excited to see this statement put out because I think it gives us more ammunition to advocate on your children's behalves, I think, to get insurance coverage for these things because we have seen that, you know, having supervised monitoring and having audible, like audio devices, things like that, might decrease the risk of SUDEP, or is at least associated with a decreased risk. So I think that was really helpful. And so I just put in a plug here for advocacy work because I think everybody, I mean, that's also part of probably why many of you are here too, but we all need to be in this effort together to try to advance. I mean, I know there's so many battles, but one of them being getting better seizure detection devices, getting insurance companies to approve and cover seizure detection devices, and then advancing the field of research for SUDEP so that we can also then start working on interventions for them. There are some challenges with researching SUDEP prevention. Just to note it, that we are aware of it. It is not, I think, something that means that we can't do it, but it is harder because there is a relative low incidence of SUDEP. Again, any instance of SUDEP is too much, but because the numbers are relatively low, at least of how things are reported right now, it means that we need really large samples of people to look at, and so that makes it a little bit harder from a scientific validation kind of view to move things along. But overall, I think what I'm hoping to lay out for you, and hopefully that I did, is to inform you or reinforce that yes, people with epilepsy, especially people with LGS, unfortunately do have a higher mortality risk and SUDEP risk. Supervised sleep and use of listening devices are associated with reduction of SUDEP risk. So if you don't already have one or haven't already spoken with your clinician about it, I do strongly recommend you consider having a conversation about seizure detection devices. They're not perfect, but they are better than nothing, and hopefully it'll let you get a little bit of sleep because you do need it. And improved seizure control may reduce SUDEP risk, especially with regards to the generalized tonic-clonic seizures. Keep an eye out for more EKG biomarker research, and then stay tuned and perhaps even help in the efforts for future studies for other biomarkers that are needed for SUDEP research and reducing the risk of SUDEP. So with that, I don't know if I have any time for questions, but thank you for having me.
Around here, but does anybody have any questions? Just raise your hand if you do. All right, we have one there in the back. I don't know if we have the mic there, but keep your hand up for our mic runner. Great. And then another one in the back, so we'll take the two questions and we'll go from there.
Just a quick question on your slide when you compared.
Please use the mic so we can all hear you guys.
Question on the slide where you compared the interventions at night. There was a 0.4 if you had supervision compared to a 0.2 if it was maybe a device or something?
Audio, yeah. They weren't comparing each other.
Okay. What is the metric or the unit? What are you measuring there?
Oh, yeah.
And how do they compare? Is it?
Yeah, so that is an odds ratio. So that is like the likelihood. What are the odds that the reason why you have an event or don't have an event is because of the thing that you used. So they found that someone sleeping in the same room, or they kind of brought into like supervision, including like seizure detection, like audio, video devices, you were 4/10, so like 60% or 60% more likely to not have SUDEP in that group, kind of. So there aren't units to the odds ratio, but it's a comparison of proportions of like the number of people who used something, had someone sleeping in the room and then had SUDEP, and then people who didn't have a sleeping device in the same room and had SUDEP. And it was lower in people who were sleeping in the same room. And same for the listening device in the room. Great
and
question.
I think there was a question in the back. Who has the mic now? If you want to stand up or raise your hand. Is there one more? No? All right, yeah, one more question. Great, thank you.
Can you tell us, please, a little bit about the future of seizure detection devices? Now that my 23-year-old has the Embrace Watch, which is the only device that's FDA approved, and it only starts recording after 45 seconds, so the home that she's living in now is only catching the tonic-clonics, which they were already catching. Is there hope that there's going to be some devices that are going to catch some of the seizures that are silent and that you don't have movement on? Or are there heart rate devices that we should be using?
I'm just gonna jump in here because Tom Stanton is gonna give a great talk on devices. So if you wanna answer with that in mind and.
Yeah, I was just going to say, I was like, I mean, I love this topic. I will say that there are algorithms that are looked at, you know, Embrace included, that are looking at other metrics like that EDA signal, for example, to try to detect seizures without that full body shaking, the tonic-clonics. So hopefully that will be in future iterations of seizure detection devices that are available.
Great.
And then EKG things, I think, because once we get a better idea of the EKG metrics, there are more uses, I think, for like Holter monitor, like things in their patches and stuff, but none of those right now like have like a feedback system like that will alarm if they detect something, so not yet, but that would be the other thing to think about for the future.
Great.
Thank you.
Thank you so much.